Fair foundations. The VicHealth Framework for Health Equity is a planning tool based on a conceptual framework developed by the World Health Organization Commission on the Social Determinants of Health. It's an action-oriented framework designed to guide policy and practice that promotes health equity. Fair foundations makes the distinction between the social determinants of health and the social determinants of health inequities. The social determinants of health are the social conditions in which people are born, grow, live, work, play, and age, whereas the social determinants of health inequities refer to these conditions and the social processes that distribute them unequally in society. Fair foundations depicts the social determinants of health inequities as layers of influence. These are the socioeconomic, political, and cultural context, social position, daily living conditions, and individual health-related factors, and how they influence or cause differences in health and well-being outcomes. The layers of influence will now be discussed and suggested as key entry points for action. Starting at the base of the framework, the first layer of influence is the socioeconomic, political, and cultural context, which encompasses governance, policy, and dominant cultural and societal norms and values. Governance refers to the system of values, policies, and institutions by which society manages economic, political, and social affairs through interaction within and among the state, civil society, and private sector. It includes the definition of needs, civil participation, accountability, and transparency in public administration, and the laws, rules, and practices that set limits and provide incentives for individuals and organisations. Policy refers to macroeconomic and social policies, including fiscal policy, trade, labour market structures, social welfare, land and housing, education, health, medical care, transport, water and sanitation. Dominant cultural and societal norms and values constitute an important part of the context in which policies are developed and implemented. Examples include the value placed on health as a collective or individual responsibility, the perceived role of women in society, and the value of upholding international obligations and treaties on human rights. The socioeconomic, political, and cultural context creates a process of social stratification, or ranking, which assigns individuals to different social positions. The process results in the unequal distribution of power, economic resources, and prestige. Key markers of social position include educational attainment, occupational status, income, gender, race or ethnicity, aboriginality, and disability. This social stratification means that different social groups have differential exposure and vulnerability to a range of daily living conditions, including early child development, education, work and employment, the physical environment, social participation, and healthcare services. The quality of these conditions affects people's material circumstances, psychosocial control and social connection, and can be protective or damaging to health. Early child development refers to physical, social and emotional, and language and cognitive development between the prenatal period and 8 years of age. This is the most important developmental phase in the lifespan. Education refers to the development of knowledge and skills for problem solving, and a sense of control and mastery over life circumstances. Education increases work opportunities, security, satisfaction, and income. Work and employment refers to the nature of employment and working conditions, including job security, flexibility, control, physical working conditions, and social connection. Physical environment refers to built and natural environments, including housing, transport systems, air quality, place of residence, neighbourhood design, and green space. Social participation refers to supportive relationships, involvement in community activities and civic engagement, or participation in decision-making and implementation processes. Healthcare services include preventive and treatment services. Accessibility of healthcare services is central to their performance in meeting health needs. The final layer of influence is at the individual level. and includes health-related knowledge, attitudes and behaviours, which result from and are responses to individuals' socioeconomic, political and cultural context, social position and daily living conditions. These layers of influence, inequitably distributed according to social position, create differences in health outcomes. Differential health and well-being outcomes are seen in life expectancy, mortality rates, morbidity rates, and self-rated health. The layers of influence will now be presented as entry points of action. Action can be at any or all layers, so there is not a correct place to start. Some examples of working to change the socioeconomic, political and cultural context include constitutional recognition of Indigenous Australians, the development of Disability Care Australia, National Disability Insurance Scheme, equitable taxation and income redistribution, local government policy that controls alcohol outlet density, media that promotes public debate about individual choice versus collective responsibility for health, and arts sector work that promotes awareness and challenges cultural stereotypes. Some prompts for planning at this layer are: consider how governance processes empower some people over others to generate and maintain social hierarchies. How could you challenge or influence these processes? Which policies create social hierarchies and exclusion of some groups? What would more equitable policies look like? What are the opportunities for challenging or influencing these policies? Which cultural and societal norms and values generate or perpetuate social hierarchies by favouring, advantaging, or excluding or degrading some people or groups? Where do these norms and values come from? How could they be challenged or changed? How could you meaningfully engage affected groups to build capacity and advocate for change? Working to address the next layer, or daily living conditions, could include early childhood development programs and services, such as new parents groups, school programs that ease students' transitions in starting and finishing school, authentic youth participation and leadership in schools, organisational policies that enable and encourage women in leadership positions, organisational policies that guarantee adequate income and employee benefits, supportive of good work-life balance, housing developments that address security of tenure, space, place, affordability and quality of housing, collaboration between planners and residents on neighbourhood quality for promotion of walking, cycling and playing, community advocacy for public transport infrastructure, volunteering programs, civic engagement for social change using digital technologies, community-controlled health organisations, state-funded, universally available immunisation programs, cancer screening, contraception and breastfeeding programs, primary healthcare, socially appropriate, universally accessible, evidence-based first-level care that gives priority to those most in need, maximises community and individual participation and control, and involves collaboration and partnership with other sectors to promote public health. Some prompts for planning at this layer are: how could you improve the quality of people's daily living conditions? How can you frame the issues to engage other sectors? What are the most pressing issues concerning community members or consumers? Ensure your program includes authentic and meaningful participation of community members or consumers to accurately determine needs and propose solutions, and to empower and build community capacity. How could your service be more approachable, acceptable, available, affordable, and appropriate? Could you also, or alternatively, work to influence the socioeconomic, political, and cultural context that creates social hierarchies and subsequent inequitable exposure and vulnerability to daily living conditions? Finally, positive changes in health-related knowledge, attitudes, and behaviours are most achievable for people who have minimal social barriers. Therefore, a behavioural or lifestyle focus on its own could increase health inequities rather than reduce them. Taking an equity focus in knowledge, attitude, and behaviour change strategies is most effective and sustainable when complemented and reinforced by changes to the socioeconomic, political, and cultural context and/or daily living conditions. Examples of action at this level include smoking cessation programs that are tailored to particular consumer needs and supported by other strategies such as restrictions on tobacco advertising, availability and smoke-free area policies. School-based sexuality education that is supported by a whole school approach to healthy relationships. Mobile phone applications for individual health behaviour change, supported by social marketing that challenges societal norms and values. Individual behaviour and risk profiling conducted in workplaces, followed up and supported by workplace health promotion strategies. Some prompts for planning are: what are the social variations in knowledge, attitudes and behaviours of interest? What additional individual level supports are needed? Could you also, or alternatively, work with others to influence the socioeconomic, political and cultural context or daily living conditions? Fair Foundations is a planning tool designed to guide action on the social determinants of health inequities for the promotion of health equity. It is designed to have relevance for any public health issue and to guide action at any or all layers of influence.